Ministry of Health of Ukraine. Krok 2. Medicine. Year 2020, number 021. A 72-year-old man with pneumonia complains of marked dyspnea, chest pain, severe cough with expectoration. T-0 is 39.5 to 40 degrees C, no urination for the last 24 hours. Objectively, the patient is conscious. Respiratory rate is 36 per minute. Percussion sound is dull over the right lower pulmonary lobe. On auscultation there is bronchial respiration and numerous moist crackles. Blood pressure is 80/60 mmHg. Heart rate is 120 per minute. Heart sounds are muffled. There is tachycardia. What tactics should the family doctor choose for the management of this patient? A. Hospitalization into the intensive care unit. B. Hospitalization into the neurology unit. C. Hospitalization into the pulmonology unit. D. Outpatient treatment. E. Treatment in the day. Patient facility. Bronchial respiration is a tubular blowing sound caused by the passage of air through a bronchus in an area of consolidated lung tissue. They are loud, harsh breathing sounds with a mid-range pitch. The expiratory length is usually longer than the inspiratory length. Crackles occur if the alveoli fill with fluid and there is air movement there during breathing. It can be caused by pneumonia or heart failure. They are often associated with inflammation or infection of the small bronchi, bronchioles, and alveoli. When the blood pressure drops, the heart rate increases and the blood vessels in other parts of the body constrict to help maintain blood pressure. Generally, hypotension is under 90/60 of a millimeter Hg. Some adults are okay and have no symptoms, not requiring treatment. But others it can result in a decreased supply of oxygen and nutrients to the brain and other essential organs, which can eventually lead to life-threatening shock. The first heart sound, S1, represents closure of the atrioventricular, mitral and tricuspid valves. As the ventricular pressures exceed atrial pressures at the beginning of systole, it is normally a single sound because mitral and tricuspid valve closure occurs almost simultaneously. Prolonged PR interval, bradycardia, 1-degree heart block, digitoxicity, or diminished force of ventricular contractions, cardiomyopathy, myocarditis, myocardial infarction, or myxedema, or densely calcified mitral valve or post-irradiation states can diminish the loudness of S1. Due to inadequate apposition of mitral leaflets, mitral regurgitation, tricuspid regurgitation, dilated cardiomyopathy, there can be a muffled S1. Early closure of the mitral valve due to raised left ventricular end diastolic pressure in acute aortic regurgitation can make S1 muffled. Conditions such as obesity, pleural effusion, pericardial effusion, bronchial asthma, chronic obstructive pulmonary disease, emphysema, and pneumothorax increase the tissue between heart and stethoscope, and the intensity of S1 can decrease significantly in such situations. The answer is A. Hospitalization into the intensive care unit.